Thank you.
Good, thank you very much. May we then turn please to item 6 on the agenda, which is the corporate and NHS performance report. Both Karen and Richard will talk to this. Karen, I think first on the corporate side, and then I'll invite Richard to talk to the NHS performance.
Yes, thank you. I'm not intending to go into detail on all of the items recorded here. I did want to say, obviously, the focus at this time of the year is in particular how we are getting on in meeting our delivery commitments by the end of the year. And the sort of amber red reports that you see here reflect the risks associated with that, the delivery challenges, but be assured we are working really hard to mitigate those and are on course with many of those action plans. It's also worth pointing out that, of course, these corporate priority programmes, we're now in the process of developing our business plan, and these programmes will continue into next year, and we are working up our business plan for each of these programmes, not only for next year, but for the next 3 years. And this will help us feed into and help inform the work that we'll be doing with local health economies in terms of developing their own 3-year sustainability and transformation plans. So that's critically important work, and I think the stability from this year to next year on those corporate priorities will absolutely help to mitigate some of the risks associated with this. So I think that's really important, just to reflect Callie's point, all of this in a cash-constrained environment. So that's one of our challenges. So I wasn't going to talk about the risks, but I'm very happy to take any questions that you may have on those as well.
Before we turn to Richard, are there questions for Karen on that part of the report? We can come back to it subsequently if not now. Margaret.
I find your reports really helpful and the breakdown's very helpful. I'm loath to add to your burden, but what I think might be useful would be to have a metric about A&E broken down so that there is some sort of focus on mental health presentation at A&E.
I'll ask Richard probably to take that, shall I?
Yes, absolutely, thank you.
Richard, you might want to come to that question, but may we take your comments first?
I'm sure Bruce might help you too. So thank you, Chairman. It's a mixed picture to report, I'm afraid. I'll try and highlight some of the key indicators that matter most to patients. Some are going quite well, some perhaps not as well as we'd like. So if I can start with one of the ones that's troubling us, and it's the A&E indicator, an indicator that requires us to either treat, admit or discharge patients within 4 hours of their arrival at the A&E department. And in November last year we achieved that for 91.4% of our patients, which is somewhat short of the target. That's consistent with the trend for the last 18 months or so, which is of concern to us all. And our tactics at the moment are to hold the best possible position we can for the rest of this winter, but working with our colleagues in NHS Improvement and also with the support of our new National Director for Urgent Care, Pauline Phillip, work on a really urgent strategy to turn around the position. That will be done through a range of means. And one concern we do have, and we've heard a lot about it already today, is the degree of variation in performance across England. Many systems and organisations are performing very well, but a number are performing very poorly, and we need to make sure that we can address that variation. We also are aware of our urgent and emergency care strategy, which has a number of key initiatives which we're already implementing in some places. They need to now be urgently brought forward and expanded and scaled across England. So a concerted drive on both of those things to see significant improvements in the new financial year, and we can come back to that in future meetings. Worth just building on the Chief Exec's comments earlier on. Clearly these data are for November. We've just gone through the holiday period and the December period, which is always our most challenging month. We'll not get the results for that period until next month's board meeting. I think we can anticipate some further deterioration in the overall 4-hour wait, because it is always our most difficult month. But I think we should reflect on the intelligence we've got about much better performance in relation to there are fewer serious operational pressures we had over the Christmas and New Year period. That certainly seems to have manifested itself in fewer extreme waits, either for ambulance delays or for trolley waits. As I say, we don't have the full data to confirm that yet, but certainly that's what the indications tell us. And I think it is important that we pay tribute to our staff, both for the planning work they did before the Christmas New Year period, and also the execution of those plans. And as well as the frontline staff, of course, who deal with this on a day-to-day basis, I think it's important we recognise the work of our own staff in NHS England. And there were some difficult days, particularly over the holiday. Directors will recall that flooding was quite prevalent in England, and we had some of our staff effectively on the Boxing Day put in a full day shift to work on a multi-agency basis to ensure that we were able to protect patients and the public from the impact of those floods. So I think that's important to recognise. The next target I want to reflect on is the 18-week target, referral to treatment. In November we maintained our position of having no more than 92% of our patients on our waiting lists having waited less than 18 weeks. We maintained that position in November. There continues to be a lot of pressure on that target too. A lot of that's down to diagnostic pressures, which I'll come back to in a moment. The next commitment I'd like to refer to is our 62-day cancer target. We have 9 cancer targets. We're actually achieving 8 of them. The one we're struggling with most is the 62-day target, which is at the 62 days from initial referral to first definitive treatment. Obviously, we've heard from Callie about the commitments we've got to improve cancer services in every respect, and that will have an impact on this target too. The figures for November were 83.5% of patients we saw within that 62-day time frame. 85% is our target. The good news is the November figures were quite a significant improvement on October, and I'd like to think, although I think it's a bit early yet, that is linked to remedial action plans that were initiated across all of the poorest performing systems in England during October and November. Perhaps the high degree of focus and Callie's arrival at least drew attention and focus to this indicator, but we're hoping those action plans will actually deliver some more sustainable performance improvements over the next few months, notwithstanding the fact that the initiatives Callie described are needed to improve performance overall on a long-term sustainable basis. So it's still a matter of tactical and strategic focus. I said I would come back to diagnostics, and again, Callie's report gave a lot of understanding about the pressures we have in diagnostics. Our target is that no more than 1% of people will wait 6 weeks for a diagnostic test. So although we set ourselves quite a high bar on that, nevertheless it's a concern to any patient waiting over 6 weeks, obviously anxious about such delays. The position in November was that 1.6% of patients waited over 6 weeks, so that's some way outside of our target commitment. The major contribution to that has been a 6.8% rise in demand for diagnostics. Some of that's to be expected through ageing, demographic change, but a lot of that increase has been, for very good reasons, earlier interventions and diagnosis, people attending screening programs, and public awareness. The Be Clear on Cancer campaign, for example, encouraging patients to look for signs and symptoms and present to GPs with those. So that's good news, but a 6.8% increase is a significant strain on resources. For a typical working week, that's 2 or 3 hours extra work to be added on. So we are doing something about that, as we heard again during the cancer presentation. Ian Dodge working with Callie on the cancer diagnosis, but also on all the other diagnoses, looking at new, fresh approaches to both increase capacity, and we are investing in capacity, but crucially to increase productivity and also to smooth flows and improve choice, so that patients don't get stuck in long queues in one place when there's actually capacity in some other part of the system to use. We've had some success in endoscopy in terms of supporting patients to move to different providers to be seen more promptly, but it needs to be extended much more widely. 2 bits of better news, and it's in relation to mental health. We set ourselves around 18 months ago targets to improve access to psychological therapies and improve our dementia diagnosis rates. Both of the targets we set ourselves, a 15% access rate for psychological therapies and a 67% diagnosis rate for dementia, have both now been achieved across England, so we're very, very pleased about that. Still more to do. In psychological therapies, we're now focusing on the length of time it takes to receive a psychological therapy treatment, and next year we'll start looking at that target and focusing on it specifically. So better news in the mental health field. Perhaps just to Margaret's question on mental health presentation in A&E, we have some data on that. We don't collect it in a way that we can nationally describe of the 4-hour waits, which were waiting for a mental health condition, and what the diagnosis and outcome of that was. Unfortunately, as I know Margaret's aware and has drawn attention to it before, many people who attend A&E have multiple problems or present with one problem, but behind that there's a mental health issue. But it's certainly an issue in terms of the improvement work, and that Pauline will lead for us, that making sure we've got really good liaison psychiatry and rapid access to mental health support close to A&E will allow us to actually give much better services for people with mental health problems. But for people who are running A&E services, it gives them access to resource that they often don't have, and it's a real strain on the operational running of an A&E department. So that's the end of my report, Chairman. Happy to take any questions.
Thank you very much. Let me invite questions and comments from members of the board. John, please.
Shall I raise I was interested about the question of sepsis. Is this a good moment to raise that? It's been very much in the headlines this week, and I had a sense of deja vu when 40 years ago, my partner missed a case in paediatrics of a child presenting with sepsis. And again, in fact, when Richard and I sat together at the SHA in the North East, we were struggling with working out how to raise the awareness of it. I'd perhaps like to ask Bruce, the challenge seems to be how we pick this out of the crowd, because it's such had the capacity to imitate, shall we say, so many normal situations where people are not critically ill. But my other underlying question is, we're hearing a great deal about antibiotic resistance and whether in fact this is going to become an even bigger problem as we get more partially treated cases, as antibiotic resistance becomes more of a threat to us.
Thanks very much, John. I mean, you raise this, I guess, as a consequence of some of the things that have been in the media recently with the death of a young child, William. And I think I'd just like to preface any remarks by saying that I know people around this board, others who I've spoken to, are kind of filled with a deep sense of sadness and sympathy for his family. And I think that's got to be our starting position, and to try and do something about that. You know, over the years, I think the clinical professions have been dogged by a number of so-called single conditions, which are quite elusive. They're very difficult. They can be at one level barn door diagnoses, and at other levels they can masquerade as something that's really quite trivial. We learnt a lot about how to deal with that when we decided to tackle venous thromboembolism, which was, I think, probably the first big clinical priority that the NHS addressed in isolation in this sort of area. And we made big progress on that, and I think we learnt a lot about how to do it. And as a consequence of the success of that, senior clinicians around the country felt that sepsis should be the next area that we should tackle. Because we all in clinical practice have been haunted by episodes of sepsis which we've missed and which have caused devastation to individuals or to their families. And because it can be quite difficult to deal with. And one of the things that we learned from venous thromboembolism is that there's a lot of things that we can do in the system, the way we run our organizations, the way we run our diagnostics, the way we run our therapeutic modalities, that we can change to make it easier for clinicians to do their job more easily and make it more difficult for them to miss things. So over the last year or 18 months or so, senior clinicians in NHS England have been working with a number of organisations, the Academy of Medical Royal Colleges, Royal College of Nursing, NICE, Health Education England, our regional and area team medical directors, the Sepsis Trust, who have done a lot of work on this. To name but a few, I will have left several names out. And the consequence of that was that we've published a plan to mobilize, if you like, the whole of the clinical community and the NHS in general to help us tackle sepsis. We published that probably not on the most obvious day of the year. It was the 23rd of December last year. But for those people who need to know about it, they do. And the document focuses on how we can improve prevention of sepsis, both in primary care and secondary care, how we can identify it more quickly, and how we can treat it more quickly. One of the things about sepsis is that it can be indolent for a period of time, or it can suddenly burst forth very, very quickly. So timeliness in all of these things is really important. So we're embarking now on a consensus approach to how we can tackle this condition, which actually you've alluded to is really pretty tricky. But I think you're absolutely right to raise the issue of antibiotic usage. And around the world, there is overuse of antibiotics, not just in a clinical setting, but in agricultural settings and other settings, which are promoting antibiotic resistance. And I think we owe a debt to Sally Davis, a Chief Medical Officer, who has brought this to the attention, I think, of the wider community. And we would be very wise to heed some of our warnings. So one of the things that clinicians are having to grapple with at the moment is, at one level, they're trying to be cautious so that they're not in the world of overuse of antibiotics, but equally they've got to get the balance right and not be in the underuse. So there's a continuing debate going on, and we're working very closely with Sally Davis and her team through the Chief Pharmaceutical Officer, Keith Ridge, and the Royal Colleges of Medicine and other prescribing groups. I think I'll stop there, John.
Okay, thank you, John and Bruce. Any further questions for Richard or for Karen? If not, then thank you very much, both of you. May we